Doctor is in.
Hey, Ricky, happy Wellness Wednesday. The doctor is, in fact, in, and we are excited today to talk about hereditary cancer testing and knowing your, not your his story, but knowing your her story, because how important is it to diagnosis, to screening, to just life and our family dynamics, to know what's going on in our families. And we want to normalize this for our families because I don't know about yours, but I grew up in a family that didn't like to talk about things like health. There were two things we didn't talk about. We didn't talk about money and we didn't talk about health. And those are two of the things that we probably needed to talk about the most.
The most, right?
Like rare cancers ran in our family. Like my mother had ovarian cancer. My grandmother had breast cancer. So when we talk to these guests, it's going to be really eye-opening. And I'm glad that everybody joined us tonight. So Ricky, who do we have here with us tonight?
We have some great friends, great friends. So I'll start with my oldest friend, Jen Michelle Lemon Kearney. And she didn't have all those names when I met her. She's my college roommate.
I was just Jan Lemon back then.
Yeah, Jan Lemon, right? So she's actually a city council member in Cincinnati. She's an attorney. She owns the Black newspaper in Cincinnati and Dayton, Ohio. So when I write articles, she publishes everything I write.
Oh yeah. Well, you're great. You're a great writer, and it's always wonderful information.
So that's how to get on the NMPA wire, which is awesome.
Yeah.
I'm glad she's here. And then we have Erica. Erica is a badass lawyer. And actually, we met on Twitter a few months ago, and she is a huge advocate for genetic testing. She knows a lot of stuff, and she's going to be great to talk about it. And then my friend Dion, she's one of my old clients. I shouldn't say old. I should say that. I had my previous.
You can say it. It's fine. I'm old, but I'm not cold. Thank you, Jesus. So there's that.
My dear friend, and she's such a sweet, precious, breasty friend of mine. And then Nicole, I met yesterday. So, our Dr. Sarah on our medical advisory team, she actually, when she saw what we're talking about this week, she said, oh, you got to call Nicole. She's got to be on the show. So she's a genetic counselor at Howard. So isn't this awesome?
This is great.
This is a beautiful sister circle of queens.
Yes, sister circle of queens. I love it. Yeah. So I'll tell you my story. So, my mom had stage 0 breast cancer 10 years before me. And she was very blessed to, really just had to do radiation, but she did a lumpectomy and radiation just for safekeeping. And so it wasn't until I had breast cancer that she remembered that her aunt had died of breast cancer at age 42. But she never talked about it when she had it. But when I got sick, she's like, oh yeah, your Aunt Louise, my Aunt Louise had breast cancer. I'm like, Mom, what is that talking about? And she could have had triple negative, who knows?
Here's the thing, right? So Black women are more likely to be diagnosed with things like triple negative breast cancer. But when you look at who actually talks about and gets hereditary cancer testing. So let me say this as an introduction. All cancer is genetic, but not all cancer is hereditary. All cancer is genetic, meaning there are changes inside that cancer cell, inside that cell's genes, in their blueprint that makes that cell live forever. It makes it reproduce, and 1 makes 2, and 2 makes 4, and 4 makes 1,000,000. And all of a sudden you got a tumor. But not all cancer is hereditary, meaning passed down generation after generation after generation. And I've become a woman of a certain age, I have to tell you. So when I talk about this example to patients, I use the example of I Love Lucy, where she and Ethel work in the chocolate factory. And for anybody who's seen that episode, she and Ethel work in this factory, and the chocolates are just coming off the belt, and they're putting them in the box, and all of a sudden the machine goes haywire, and the belt's going faster and faster, and they're stuffing chocolates in their pockets, in their face, in their hat. That's cancer. But not all those factory mistakes get passed down generation after generation. That is heredity. Only 5 to 10% of all cancers are truly hereditary. But for people who have those risk factors and who have those changes in their genes, like, Ricky, you and I, we talked to Matthew Knowles a few months ago, BRCA2 mutation. People who have changes in those genes have a higher likelihood of developing cancers in their lifetime. And so they need higher screening. They need maybe things like prophylactic surgeries. There are clinical trials, there are medications. There's lots of things we can do to prevent cancers for those people. And we're going to talk to a pre-vivor, tonight. But people don't really understand the difference. So when I talk to breast cancer patients and I'll say, well, have you had genetic testing? They say, yeah, I'm ER/PR positive. Well, those are your hormone receptors. And that's something totally different than this genetic testing. And so it's important to know, because Black women are less likely to get referred for genetic testing. 26.7% of Black women versus 47.5% of white women. And this is a real problem in our communities because, okay, now they meet criteria. Now it's on our radar. But what if you had cancer back in, 2000, back in 1995? What if you were meeting that criteria? And you can get that testing now. So I want to use that as a launching pad for this conversation about what women can do, even if they're survivors and they're already through their treatment. How can we go back now and get that information for our families and have these conversations? Because that's where we got to go with this thing.
And Dr. Mo, can I ask you a question, please? So even if you have like a BRCA2 gene, I know we're going to talk about this. Does that mean is there something you can do to prevent getting cancer, even though you're predisposed to it?
Absolutely. So there are different things that we can do either medically and also surgically to reduce the risk of cancer in one's lifetime. Absolutely. And we can talk more about that. But a lot of times it ends up being one, increased surveillance. So until the time that a person is ready to do things like a double mastectomy or removing of ovaries, we can know how much and how often to screen. There are medications that we can talk about that will help to block estrogen. We talk to some patients about things like birth control to reduce the risk for ovarian cancers for certain patients. So there's some things medically. And then nutritionally as well, like we can boost our nutrition and our immune systems to help fight, the cellular changes that can happen and that are predisposed to happen for us too. So there's a lot of different things that we can do to help try to reduce the risk, but at least when we get that testing, we can know what to watch out for, because a lot of people don't even know what all the cancers are. They just know, okay, breast cancer runs in my family, but they're not checking for ovarian or for uterine cancer or for melanomas. Like Black people aren't always checking for things like melanomas, and we got to put that stuff on our radar. So that testing can be helpful to tell us how vigilant to be.
That's really interesting because I think that's what happened with me, right? So my mother I'm originally from the Caribbean, so everything is a secret. You only know what you need to know. So she had a diagnosis, and I didn't know much about it until I got my diagnosis. When I was around the same age, she was 48, I was 47, and I had a lumpectomy, same sort of surgery and treatments. It's the same thing that happened with me. It was almost mirroring each other, but when I had my first colonoscopy when I was 50, and I had 10 polyps, 7 of which were questionable. And I didn't think anything of it, and I said okay. And when I moved to Florida about 5.5 years ago, I became a patient at Cleveland Clinic, and my general practitioner kept on, she had the records from my previous life in New York, and she just kept on. She was is an Asian woman, kept on keeping track. And last August, my mother, who is now 84, was diagnosed with ovarian cancer. And she says, wait a minute, Dion, so your mother had breast cancer, she's got ovarian cancer. Oh, you need to get tested. You had this thing with your colon. I had 2 patches of my skin removed in my back because of skin cancer. So, all these things, she says. So last week I began the blood work to begin the genetic testing. So I'm the oldest of 4. I have 2 sisters and a brother, but there are other cousins. I have first cousins. I have 2 that have died because of one breast cancer that metastasized into her brain. She was 42 when she died, and the other was 40 when she died. Same thing. And so but for me, it's been prodding. Mom, how did that happen? Mom, or calling somebody else who may know more, one of her sisters, and it's been that sort of like swirl. So this is very empowering, to sort of hear from folk whose walk have been very similar to mine, right? And can kind of say, you're on the right track. You're going to be okay. I have, as I said earlier, I have a daughter that's 31. So I am laser focused on making sure everything that happens to me, she's like either there with me or I'm regurgitating it as it's happening step by step, because I think we owe it to each other, right? We owe it to, it's a part of the legacy, and that old school stuff of, they don't need to know what they don't need to know is nonsense. And I
Yeah.
won't participate in that. Yeah.
And what you're doing, Dion, is you're shifting the paradigm within your family. And it's something that I see a lot with the patient. So I have like a specific generation that, went through their cancer by themselves. They didn't tell anyone, stuffed their bra with shirts or socks. Nobody knew they had cancer. Then I'm seeing their children come in and they're like, well, should I share this with my family? And then they do. And then I'm seeing, people like you come in and you're bringing your children, nieces, nephews, getting on the phone, family conferences. And I think that's so important to have those discussions, especially when it comes to the female cancers, that often aren't discussed, where it makes a big difference when it comes to genetics. So we know ovarian cancer can be hereditary, but not so much cervical. But if we don't ask those questions and say, what type of cancer did mom have or auntie have? And they say, oh, it was that female cancer. Well, what does that really mean?
Exactly.
To have those conversations and have it documented. So I'm so happy to hear that you're engaging with your daughter in that way and inviting her into the room and having conversations with her, because it'll make a difference for her, for her life.
But you know what? It's scary though, isn't it? I mean, like I'm thinking about for me, I was diagnosed with cancer in 2012. And, Ricky came up and went with me to the doctor and, she's a godsend. And she said, have you been tested? Do you have, one of those genes? Because, you've got a daughter. And so you really need to get tested. That was in 2012. And then every now and then she would say, have you been tested yet? But let me say, my doctor never said, you need to have genetic testing. But Ricky every now and then brought it up. And I'm like, no, I still haven't been tested. So I just got tested like 7 years after being diagnosed with cancer, which is a long time. And I think part of it was just fear. And then, when the results came back, like, you've got BRCA2, so I have a higher risk of breast cancer. I'm like, no surprise there, been there, done that. But then they said I also have a higher risk of ovarian cancer. And so, I'm like, let's get rid of it. Let's, so I had the, what is it called? Oophorectomy. Like I had the ovaries taken out, the entire hysterectomy. I'm like, I'm just not messing around with this.
That's right.
I was shocked, but on some level, I think I was afraid to know.
Yeah.
But knowing that I had a daughter, I had to keep pushing. Yeah.
Yeah.
Nicole, you caused me to have a flashback to a memory of being a little girl and hugging my grandmother, and her breasts were crunchy, and I didn't know why. And I discovered as I got older, she stuffed her prosthetic bra with money. And
Wow.
Really? Wow.
she would hide tens, 20s, $100 bills in her bra, and you give her a hug and it would crunch. And I never knew why. And God bless her, because she went through this journey without really relying on many people and without people. And it was after she died that I kind of got to even know what type of breast cancer she had.
Wow.
It's really something, we're sick as the secrets that we keep. And there's so many people watching right now who don't know how to tell their families. And I wonder if some of you could talk about even just how do you start that conversation? If you're not used to talking about these things in families, how do you even start that conversation?
Yeah. Eric, how'd you start it?
Well, it's interesting because for me, my mom is a 2-time breast cancer survivor, but my grandmother was also a nurse. And so I think, my grandmother like instilled in my mom and myself, like very early, like you ask all the questions, right? Like you ask the doctor lots of questions. You don't have to just take whatever they say, right? If you don't like the information you get, you push, right? And she really, I was thinking about it recently. She did that for everybody in my family, right? Like, so anytime somebody was going to the hospital for something, they'd be like, we got to call Ethelene, right? And ask her what's going on.
Her name is Ethelene?
Yeah.
That's my mother's name, Ethelene.
Oh, wow. Yeah. So it was like, we had called Ethelene because, the doctor's telling they're going to do this. What does she got, but also, kind of talking about like access to genetic testing. So like, I think the reason that my mom did get genetic testing is because when I was a senior in college, I was at UNC. And when my mom got cancer the second time, she decided to get her treatment done at UNC because she's like, oh, well, you're there. I can stay at your apartment if I need to. And so I went to all my appointments with my mom because, she was getting her chemotherapy and surgery done at UNC, right? So I went to the appointment with her with a genetic counselor when they were like, she has BRCA2, you have a 50% chance of having BRCA2. I will say that like, we have not been able to convince my mom's siblings or my cousins to get tested. And so I kind of think like, we just kind of have ongoing conversations, right? To sort of say like, hey, this is the circumstances. And,
Yeah.
you know, I kind of just periodically try to have those conversations to push. But
Yeah.
it's
So
hard.
Erica, you've already been tested.
tough.
then?
So yeah, so I underwent genetic testing in June 2014, and I got the results in July 2014. So it came back positive that I had
It took
inherited.
that long.
Oh, it took like 3 weeks because it was
Oy
like I did
vey.
it at the end of June ish, and then I got the results like I think 3 weeks in July to get the results. So because of my family history, because my mom had cancer the first time when she was only 28. And then my mom, when she had cancer again, she had triple negative cancer. She had cancer to different breasts. So I think the cancer in my family is very aggressive. So I had a double mastectomy at the end of 2014. But that was largely driven by, you know, family history, right? You know, and some of the doctors were like, you know, if your mom had cancer in her 40s, we would just tell you to have mammograms and MRIs and come back. But, you know, having cancer that young is pretty indicative. So,
Right.
you know,
Because, you know, the screening, so mammograms are not as effective. And any woman who's gotten her letter from her mammogram and it says the sensitivity of mammography is limited for heterogeneously dense or greater breasts, right? And you get that letter and that statement and you're like, well, what does this mean? The thicker your breasts are, the harder it is to see what's going on. I tell people it's like static on a console TV. And again, I'm showing my age. But if you remember the snow on the big console TVs, the more static you got, the harder it is to see the picture. And so women who are very young, they have a lot of density. And so mammograms are not useful for women in their 20s. It's not as helpful. They need things like ultrasounds and MRIs. And when you have a family member with breast cancer, you know, 23, 26, something like that, well, when do you start screening? At 16?
Yeah.
How do you begin screening? And so it's really important to know, you know, that family history, because if you won't know how soon to even start screening, even if you don't have a mutation in your family.
Right.
Yeah.
Wow.
I have a cousin, my first cousin, she died at 42. I shared with you all earlier, but her daughter, my second cousin in her early 30s also had a double mastectomy. And I have been trying to reach out to her to say, she's in LA. Hey, you know, what were the results? I am very, very vocal about all of this and you know, sharing, especially for my daughter, as I said, because my mother-in-law also had a double mastectomy when she was about 50. So, you know, I don't know why, because there's that. But still, there's an awareness, right? Because I talk about it enough. But I'd like to know more about the cousin in LA and why, you know, what were the results that she had gotten. But I think it's important, as you know, they're quick to say, elders are quick to say, knowledge is power, but it only goes to what doesn't concern them, right? Knowledge about everybody else's business is powerful. But when it comes to themselves, it's like, ain't none of your business. So
Right.
right.
I mean,
I
like
don't
tell
know
you,
why that is. I don't
you
know
know,
why
myths
that
about
is.
hereditary cancer testing. You know, did you guys ever grow up hearing, well, it can skip a generation, or maybe it's only mother's side on your father's side, things like that. What are some of the things you've heard about how cancer passes down?
I heard the skipping generation part because my mother didn't have my maternal grandmother had breast cancer, but not my mom, and my mom lived to be 86, and so she didn't have cancer at all.
But your grandmother did? Yeah, I didn't know that. Yeah.
Yeah, my mom's mother. Yeah, Ethelstein actually was her name.
How do you know how old she was when she had it? Was she young?
She was, yeah, well, she, you know, it seemed old back then, but she was like in her mid 60s, which seems pretty young now.
Yeah.
But back then it seemed, you know, so yeah. But let me tell you guys about the, you know, double mastectomy. So my surgeon said, you know, she wanted to do one breast, which had the cancer, but she's like, you don't really have to have both. And so I was like, oh, you know, I don't think I want to do this. And so I talked to Ricky about it. This was kind of funny. And Ricky was like, get rid of those things. They're trying to kill you. I went back. I went, okay, double, let's go.
It's so true. I'm all about the double mastectomy every time. You know that.
Yeah, she's like, get rid of those things. They're trying to kill you.
I will.
Go ahead, please.
I was gonna say, Dr. Gary, to your point, you know, it's not so much for cancer, but like amongst my grandmother's brothers and sisters, there are 11 of them. All of them have had some type of heart problem, heart attacks, strokes, right? And it's only been as an adult that I'm like, oh, that's probably a genetic component to that, right? But as a kid, I just kind of, even as a teenager, it was kind of like, oh, well, that's just, it's a thing that runs in our family. but I didn't really, until I was older and went through this experience, was like, oh, right, that might be genetic.
Another
right?
thing. Mhm.
So
Yeah, and Nicole, isn't there more genetic testing now than even we thought initially? So people who got tested, like I got tested back in 2013 or so. And back then it was BRCA1 and 2, and there were a couple other genes. And now like the world of testing has exploded. Can you tell us a little bit more about, what that testing looks like now, especially for people who might have just got BRCA1 and 2 testing?
Yes, absolutely. That's such a great point. So going back to, I would say the 2000s, we historically tested for BRCA1 and BRCA2. Those were genes that carried mutations that were more prominent in the Ashkenazi Jewish population. So that's really what we knew the most about. And then as time carried on, we knew more about other genes like CHEK2 and PALB2, TP53, there, BRIP1, all these other genes. But now I use a panel that has 84 genes. So there are some counselors that kind of keep it limited, but I like to test the full gamut. For one, because of what we're talking about now, we don't fully know the family history. So there could be someone in our family with ovarian cancer or with colon cancer or with stomach cancer that we just may not be aware of. So I want to make sure that those genes are included in the panels just to be as comprehensive as possible. And then there are insurance barriers where, like I know for Medicare, I'm not sure if it's still the same, but for a while it was you have once in a lifetime for genetic testing. So if you got, before, if you got BRCA1 or 2 testing, then you couldn't get a panel. So hopefully that's changed by now, but it is far more extensive than it used to be. So if someone only got BRCA1 and 2 testing previously, they may want to speak with a counselor to get update testing, is what we call it now, where you can get a more comprehensive panel done.
Nicole, I have a question for you. So, when I got my testing, I had my mom's results. So they were only testing for that specific mutation. But would you recommend for someone, would you still recommend that someone do the broader panel test, even though they might know the specific familial mutation?
That is such a good question.
Mhm.
So in our training, that is exactly what we're taught to do. So if there's a known mutation in the family, that's exactly what we test for. I would suggest testing for additional genes if there are other cancers in the family outside of the one that you got tested for, or if there's cancer on the opposite parent side of the family. So right now, we're tracking your mother's lineage, but say on your father's side, there are 2 or 3 different types of cancers. We're missing those because we only tested for that specific variant. We didn't even test that full gene. So they didn't even analyze all of BRCA2. They only looked for that specific mutation in BRCA2. So that's an excellent point. And I think it will vary person to person and family to family. So the important part is to meet with a counselor and get that 3-generation pedigree done to look at the patterns in the family and see if that was the most comprehensive test for you or if you should expand it out.
Yeah.
Well, now I have one more question for you.
Okay.
So to that point, so I don't have any, so I don't know my biological father. So I don't have any access to my biological father's family history, right? So then what does someone who maybe can't get the family history do?
Exactly, a panel.
Okay.
So that would answer the majority of your questions without having that information. And I'm honestly so glad that we've gone the panel route, because it used to be test these genes, okay, those are negative, test these genes, okay, those are negative. Well, we can just do it all at one time, because there are a lot of us who are adopted, raised by a different family member, don't have history. I have a lot of patients who are from South America, from Africa, that haven't been to their home countries in years and really don't know what their aunts or uncles or cousins have been diagnosed with. So I say a panel, speak with a counselor about a panel, and it would give you more insight.
Very true. And I love that you brought that up, Nicole, because I have seen families that have more than one mutation. So people who are watching understand what we mean by checking a certain location on a gene. These genes are like ladders. And they're gatekeepers. They help to prevent the body from making mistakes, and they search up and down the rungs on the ladder. And we kind of know what each one means now, which is why we're able to do a panel of 80 genes or whatever, because we kind of know what the rungs mean. And so we look up and down the ladder looking for mistakes at certain places. And if you have a change at that certain location, that predisposes you or puts you at higher risk for cancer. But some people have more than one mistake on the same ladder. Some people have mistakes or changes on multiple ladders. And so, we can find people who have a PALB mutation and an ATM mutation or whatever, the different gatekeeper genes are. And so when we only test for what runs in your family, then that's all we know. Right. Check that one wrong. but it is important to consider looking at the rest of it because there are other cancers that you might be at risk for. We might need to understand what your screening could be for cancers that aren't related to, let's say, a BRCA mutation. If you have a mutation in P53 or something else, there's other cancers we can watch out for and screen for.
I know. You know, a lot of the new drugs coming out too for triple negative especially require a special genetic profile like PD-L1.
Yeah.
So, right. So like Keytruda and Tecentriq require PD-L1. And so it's so important even when you get breast cancer to know what your profile is because it can impact the therapy that you get on, you know?
Okay, I have no idea what you're talking about. What does that mean,
I was
PDL?
just gonna say, Ricky, you bring up an important point, genetic versus genomic.
Genomic. Yes.
Oh, wow.
Break it down, ladies.
Can't pass it off to you. Genetic versus genomic.
What'd you say?
Genetic versus genomic.
Genomic. So there's so much, even somatic and germline. Oh gosh. Okay. So
This is what
you have
happens
great
when
analogies.
scientists get together. Scientists
Okay.
get together. You all start talking this language. It's like, what? What are you
Right.
talking about?
But I am a willing student, so please
And me too.
teach me.
I am
And
not
I
a
was like,
scientist.
woo.
So there are so many different types. So I'm gonna try to bring it together. Dr. Mose is excellent at these analogies, but at least when it comes to genetic testing, so there are several different types of testing. So what I like to think of first is somatic, which is body. So I think about the tissue. So the breast tissue has its own specific mutations that you tend to acquire just over your lifetime versus germline, which is what you're born with. Can't really be changed. It is who you are. You know, we have skin cells that fall off the same exact color skin is going to grow back, you know, same with our hair. So germline are things that can't be changed that are hereditary that we were born with versus somatic. So these changes that happen somatically in the tissue are where they will test to find out what drugs work best for that cancer.
Okay.
So when it comes to PD-L1, they can do PD-L1 testing. If it's PD-L1 positive, there may be a medication that works best for that mutation. So they're doing tumor testing now to figure out what type of chemotherapies work best specifically for that tumor. But then germline testing is specifically to find out if your genetic makeup is predisposing you to cancer.
Okay.
And then there's a difference too when it comes to saying I have the gene. We all have the genes. We all have BRCA1, we all have BRCA2, we all have the same exact genes. In fact, we have two. We get one from our mother and one from our father. The question is the gene mutated? Is there a change in the gene that is causing the gene to no longer function the way that it should?
So everybody has BRCA1 and BRCA2?
Yes.
Oh.
Exactly. Yes. Everybody. And that's the biggest thing is like, oh, wait, you have that gene? We all have the gene. The question is the gene functioning? That's the question.
Okay.
So when people say they're positive for a mutation or they have a BRCA2 gene mutation, it means that there's a change in the gene that's causing the gene to not produce a protein that will fight against cancer, like a gatekeeper, a tumor suppressor. There are different types. So that means that the gene isn't functioning the way that it should.
Wow. Well, so I had the bigger panel last year, right before COVID. And so Dr. Hampton, my doc, called me and to give me the results. And she said, well, you have no mutations. I said, well, that's good, right? She's like, not really. We don't know.
Yeah.
Oh, what?
Yeah.
Right? Because a lot of this testing was based upon European women. It was based upon Ashkenazi Jewish women. It was based upon we learned about these genes not from us, interestingly enough, not from experiments done on us or genetic testing done on us, but on Europeans and white women. So the locations on that ladder are relevant to them. Some are unique to them. And we're trying to now go back and figure out, are there unique locations where there might be changes for Black women, for Hispanic women, for Asian women? How can we know that, you know, the spot that causes cancer in European women is the same spot that causes cancer in Black women? And the answer is we don't entirely know yet. And so you'll see these genetic companies are doing a huge thrust to try to appeal to Black and brown women because, you know, we historically had been denied that testing. Our insurance might not have covered it. Our doctors didn't think we needed it. It was something sort of secondary because, you know, we had so many other things to deal with. And let's just be real, you know, there's been a disparity in genetic testing, but now they want to go back and they want to look and they want to try to understand if there are racial and ethnic differences in the gene expression or how those genes work for us. So it'll be
Yes.
really interesting to see in the next couple of years.
Yes, and even to piggyback off of that, just something that I've seen, I work primarily with African American, Hispanic, and African populations. And there's another result that we can get other than a positive result and a negative result, and that's the variant of uncertain significance. So that's where there's Dion's like, what?
What does that mean?
Oh my goodness.
So that's where they are uncertain about the result that they have found. They don't know if it makes you 5'3" or if it's increasing their risk for ovarian cancer. You know, they really don't know. And it's because our population has not been included in genetic testing. So they have these databases with hundreds of thousands of women, and there may be only 100 women of color. So when they find these variants, it's like, oh, wow, we've never seen this before. So they have nothing to really compare it to. So it's really been a struggle working. I'm at Howard, and oh my gosh, I just really forewarn people, you know, it's very likely that we're going to get a variant and we may not know what it means. And I have some patients that come back with 3 variants. I've had some that come back with 7.
Wow.
So here we are teasing through all of these different variants. And the interesting part is some of the genes that come back inconclusive or uncertain match the family history. So then the question is it really positive or is it still uncertain? But we really don't know until more of us get tested and we're included in research studies and in these different trials, and that other labs to start to share their data, because a lot of labs keep the data to themselves. So other companies and researchers don't have access to the information that they specifically have access to.
Now, that's ridiculous. They ought to be sharing.
Well, I will say the flip side to that, though, is that that data is protected, because I did a lot of research on this, because we got a problem with sharing in public spaces, our
Yep.
genetic information, right?
Okay.
And so on the one hand, some companies don't share, but your genetic information is proprietary and protected. On the other hand, it goes into a database that other people can access. And by other people, I mean like scientists. You know, it'd be like looking at numbers. You wouldn't understand what you're looking at for the average person. So nobody's going and accessing that. But it goes both ways with that sharing of information. And some women like the fact that their stuff is not shared. But I think in general, you know, if we can share it with the research community, it can help us to figure out what some of those variants are, because the longer the panels, the more panels you do and the more genes you test, the more likely you are to get those variations in the gene. And the way I explain them to patients, it's like in general, and this is a huge generalization, it's like having blue eyes and brown eyes, or you don't test your green-eyed child for blindness. Everyone has variations that make them them. And if we test cancer genes, we can find variations on the gene that don't mean cancer. It's somewhere further down the ladder than the spot that we know of that causes cancer. But what if you got that spot and your sister got that spot and your grandmother got that spot and everybody got that spot, but we haven't classified that as the hot spot yet? Like, what do you do for that? And so we're finding that, like Nicole's saying, with a lot of Black and brown women, because there's just not enough information about what's going on in our genes to be able to tell us, you know. And so it's tricky as a surgeon, because do we do double mastectomies? Do we take out ovaries? What do we do for these women when they don't have the hot spot? They got some change somewhere else.
Take it all out.
Yeah.
Rid of it.
So, you know, my
Ricky solution, get rid of it.
I'll give you an example. My sister doesn't want to be tested. You know, with our family history, she said, listen, if the train's coming, I don't want to know. How do we talk to our families about this? And maybe, you know, from people who have been through this, tell us some of the things that make you feel empowered and some of the things you wish you had known. Because I think that's the other side, is it's not all roses on the other side of a double mastectomy, right? There's some things that you maybe wish you had known and could help to manage a little bit better. So give us the real talk about this.
And, you know, Dr. Mo, so that brings up my question. You know, you get tested, you get this information, what do you do with it? Like, is there a way you can prevent cancer, or, you know, like what do you do? I mean, like, knowing that you know, you have this, you know, genetic profile or have these, you know, mutations, you know, how does that help us?
So your question was, how does it help us to know if you have these mutations?
In other words, what can we do about it? So, you know, to know that we have, you know, like for me, knowing that I have, you know, BRCA2, or someone else knowing they have BRCA1, and all the other things Nicole mentioned, which I don't know what all that is, but, you know, like of the 84 genes on the panel, you know, when you find out, okay, you've got these mutations, what can you do?
Gotcha. So I think the first thing you want to do is certainly talk to your doctors and come up with a plan. So every woman that comes to my office for genetic testing, and when we get the results, we develop a personalized plan of what looks like prevention. If you've already had a cancer, then we talk about how to prevent future cancers. But if you haven't yet, what does your prevention plan look like for whatever cancers you're at risk for? What are we doing for breast? What are we doing for your colon? What are we doing for skin and melanoma and everything else? And we kind of work that plan every 6 months, and we come back together. Okay, where are we on this? Did we get our colonoscopy? How are we doing on these other things? We talk a lot about nutrition and prevention because, the more antioxidants we consume and the more things we put into our bodies to help boost that immune system, our cells and our body can try and do repair itself. And we want to boost those self-healing mechanisms so that we're not just relying upon medications all the time. As people of color, we believe our bodies can heal themselves. And so I tap into that with patients, and we talk about what that looks like. On the advocacy side of things, education, education, education. Because by the time a woman gets a breast cancer, her head is full and is swimming. And if you haven't heard of these things beforehand, then it's really hard to wrap your mind around it, while you're in the middle of trying to figure out what to do with your kids and your parents and your job and FMLA and am I going to need chemo and, all the other stuff. So as much as we can, contribute to health literacy and advocacy, and then if people really want to get involved, I can tell you that every single genetics company right now that I partner with is looking. They are searching for Black and brown women, and they are doing global ancestry studies and trying to go all the way back to Africa to figure out what's in our genes. And so they are interested in hearing from you. They're interested in partnering with you, and you can become an advocate and a face for these sorts of campaigns to help educate Black women and help recruit into clinical trials too.
Okay, great. Thank
I
you.
mean, I guess I'll share a little bit about because I wanted to make sure Dr. Gary, I answered your question about what I wish I would have, why I did it, and which I wish I'd have known. I mean, I think for me, like seeing my mom go through, breast cancer and chemo, like really weighed heavily on my mind. In part because, my mom had cancer, and then my mom was in remission for 14 years. And so my mom's like, cancer is a thing I'm done with, right? I've been in remission that long, it's over. And when she got cancer again, I feel like she almost had like PTSD because she was just like, I was not expecting this to happen. So for me, I was really thinking to myself, okay, I have this mutation that gives me like a 70 to 80% lifetime chance of developing cancer, breast cancer, at least that's pretty high.
Right.
And if I can do something about it beforehand, right, and drop that risk down, that's worth it. And that's something that my mom did not have the opportunity to do, right? And then I also thought if I was having a mastectomy, it would be easier to recover from the mastectomy if I wasn't also fighting a cancer diagnosis at the same time. And also like very in a vain way, by the time I had my mastectomy, they had sort of like finalized the science around nipple sparing mastectomy. And I was like, okay, well, I can also keep my nipples and have a good cosmetic outcome. So that's like important. That's important to me too. But to the point about a plan. So like I see a woman at NYU who specializes in high risk patients. And it's what, you talked about, right? So every 6 months, she's like, did you get your ovarian screening? Did you get your melanoma screening? We got to remember to start your, colonoscopies, right? I mean, my hope is that, there's research that ovarian cancer actually starts in your fallopian tubes and then migrates from the tube to the ovary. So my hope is that when I'm like 38, 39, I can just have my fallopian tubes taken out and have a normal menopause and then have my ovaries taken out. But I think the science on that is still developing.
That's interesting that you've created a plan already.
Yeah.
I admire that. That's that is really what you call self-advocating. And so I have to salute you for that. I had a hysterectomy in my late 20s, but they kept my ovaries. So that's the swirl in my brain right now too. Damn it. Now I have to worry because mom is 84 and she had, this past August. Now I have to tell you with mom, her oncologist recommended chemo and she refused because at the same time my dad has dementia. He died in February. So she was dealing with that. And so she refused treatment. And now my youngest sister, when my dad died, came to help my mother. And she says, something's wrong with mom. she is shrinking. There's something wrong. And, I had tried to have a conversation with her saying, she needs to make an appointment and that my youngest sister would go with her. And she says, no, what's happening with me is nobody's business. So,
Mm.
when you asked about, how do you start that conversation? I immediately after surgery, I would walk into the rooms with my sisters and whomever, and I'd take off my bra and say, look, see, look, that's a scar. Look, see, that's what they did. And, or anybody, I mean, with even almost strangers, to which my husband doesn't like too much, but I'm quick to say, look at my scar. This is what happened. And, and you see, look, because I think, there is something, I feel like I'm taking power away from whatever could be and saying, yeah, no, not today, devil, not today,
There you go. Yes.
and that's just, that is just my attitude, with my sisters. When I talk to them, I'll say, let me see what your breasts look like, or, and initially they used to go, what is wrong with you? But now they just go, here, D, have your way, have your way. And it's, it's for a
Good for
reason,
you.
right? It's,
Right. Yeah.
yeah, my daughter always says, "Oh, y'all just want to look. You all got big, big African nipples. That's what you want to look at." It's like, well, if that's it, then that's it.
I made
But
everybody feel
You
my
all
love when
love
I
that.
had it. I made everybody feel my love because I wanted people to know what it
Yeah,
felt like. Men, women, I
yeah.
didn't care. Just feel this because I wanted people to know what it feels like. So I think that's so important. I will definitely pull up my shirt in a heartbeat too. So I'm right there with you.
Oh, yes, you
Oh,
will.
Jan. Oh, I I just thought of something because you were talking about what can you do to prevent it.
Yeah.
So I don't have children yet, and I don't necessarily know if having children is in the cards for me. I don't know, but I will say, like, part of the benefit of knowing that I carry this mutation is that if I wanted to, I could do egg freezing and IVF, and
Right.
then choose not to pass the mutation onto my children, right? So I could potentially eliminate this mutation in my line, right? So now that's a very expensive and time-consuming process, but it is something to. It's called pre-implantation genetic diagnosis.
Yep.
Really? So you could change your genes?
Well, not
No.
change mine, but like they would. So I would, like, freeze. They would take my eggs, inseminate them, and then they would only implant the eggs that tested negative for carrying the BRCA2 mutation.
Oh,
So I
that's
could
Wow.
choose, yeah.
Mhm.
Wow, that's amazing. Wow. Say that again so people hear that because that's huge.
What, right? So it's pre-implantation genetic diagnosis, and so it's a way using IVF and testing to prevent passing on hereditary mutations to your children, to the
Wow.
child that you're having.
And,
So they
and
test your eggs to make sure that you're only passing along the eggs that don't have those mutations.
Mhm.
and the
Oh,
reason that
that's
happens
awesome.
is because you
Yeah.
got the 50% chance of inheriting a mutation, right?
Wow.
And so if you had 4 eggs, 2 of them will have it, 2 of them won't. And
Mhm.
so when you look at families, even, some families, one sibling ends up with it and some don't. And so if they can know ahead of time which embryos don't have that mutation, then they can implant those embryos. And, it's really fascinating research. And it is expensive, but it is something that a woman should know as far as knowing her options. And when you know your history and when you know what's in your genes, you can try to plan for those things. Now, I will say there are some people who develop these mutations, we call it spontaneously. Like, it's sporadic. It didn't necessarily run in your family. There are some people who have these mutations in their tumors. And so because it's in your tumor, and this is what Nicole was talking about, it's not necessarily what we call germline or hereditary, but your tumor developed that mistake, which is why it was able to live forever. And so, it gets really tricky and really complicated. But, Erica, I love that you are able to have those options at least,
Mhm.
and that's
Yeah.
a beautiful thing to be able to have those options.
So
And
it's not,
also too, knowing that I have the high risk for ovarian cancer,
yeah.
I did look into egg freezing just in case, right? So
Yeah.
if something were to happen, I could at least preserve my fertility.
Right.
Yeah.
I think for me, thinking about egg freezing, because it's such an kind of intense process, I was kind of like, the mastectomy was enough for right now. Like, I don't have to go down that road. But to your
Yeah.
point, it's about having the knowledge
And
and the
not-
options that it's available to you.
Mhm.
And
And you
planning.
give
I
yourself
mean,
that power, you
Yeah.
claim that power. I think that's beautiful. But I have a question, Dr. Mo, when you talked about um, not genetic, connection, but could something could be in a tumor? Would that be associated then with the environment? What would be the correlation to that taking place?
Gotcha. So in order for a tumor to develop, changes have to happen inside those cells. And those changes are genes get turned on or off. Some, like the spell checkers or the gatekeepers, become sort of faulty. There's a whole sequence of things that happens. And when we look at things like colon cancer, for example, in colon cancer, we now know what the steps are for a cancer to develop, even from a polyp. And we know what genes go wrong at what stage of development, and we can like intervene before a colon cancer even develops. It's not quite that way for breast cancer yet, but we know that there are certain mistakes that do happen in that cell that predispose it to live forever. So when we talk about, Ricky mentioned PD-L1. PD-L1 it's a ligand that helps a cell it helps the immune system to repair itself. And so there are certain people whose immune function is impaired, and we know that there's drugs that can help to target that so that their immune systems won't fight against the cancer drugs. So we can look inside our bodies to see what signals get turned off and on like a light bright. And we can get whole panels and reports of what your tumor is sending out like a bat signal. And whether or not your tumor the genes are turned on to tell cancer to happen early, to tell cancer to happen late, to tell cancer to happen just in the breast, or to tell cancer to happen outside the breast. And we can know, so even that testing, like for example, the oncotype testing that tells women if they're going to need chemotherapy, it looks at gene expression in their tumors. And it looks to see if the genes are turned on, they can't tell cancer to happen somewhere else. If that bat signal is high that says cancer happened in the liver, in the brain, somewhere else, then we know you need chemo. Versus if your signal or your bat signal is lower for certain genes. So there's a whole science behind what's going on in our tumors now. And this is the promise of personalized medicine, is that we can figure out what you need, not all the women your age, all the women your stage, all the white women your age or stage, but what's going on in your tumor that then would respond to certain medicines. And this is why we need Black and brown women to even consent to do this type of testing, because sometimes they don't always want this testing, or they're not offered this testing more often than not. They don't know they have the option of it.
Right.
So there's a lot of things that we can talk about with your doctor, as far as when you get cancer, to know what's going on in your genes and what's going on in your tumor.
So Mo, I believe that Black breast cancer is different, that we have a different disease, we fight a different fight, the numbers just are against us. So who is the keeper of all of this data? So can we have, I would love it if we had this big repository, so all of this genetic data is sent to some place or whatever, some big house, some big factory, some big lab, and they can aggregate all the Black women's data and say, okay, Black women, 20% of Black women have this thing, or 30% of Black, and start to kind of look at the science of our genetic makeup. Can that happen? Is that crazy?
Well, I just put in the chat the link for ClinVar. So ClinVar is the repository for all of this genetic data. And it's for all the companies that do testing that will share it. And it's a place where you can go to look to see what different genes are, what they do. And many companies will update, and science labs will sort of make changes as we learn more about different genes. It's not regulated by anything really, other than I think the government. So there's not a whole lot of oversight and regulation. So if a lab discovers something and then they go in and insert it, there can be some challenges. And I think the scientific community regulates itself. So a bunch of researchers, if you go making change to the BRCA gene, the information about it, researchers are going to come back and say, hey, how do we know this is valid?
Right.
But it's the repository for everybody and everything.
So there is one. So that's good. We need to talk to them.
There is, it's government, and it's just it's a website, and it's a global repository. You would have better traction, I think, talking to different companies that offer the testing, because those companies can then do the research for you to understand, okay, we have, out of 100 Black women tested, 25 of them have a change on this gene at this place, what gives? And then they can put the money and the resources into understanding why women have this change here, Black women, and why Asian women have this change somewhere else. And that's part of their job. So partnering with those companies, genetics companies like Myriad and Ambry, Invitae,
Invitae.
Yep, those are great companies that are looking for advocacy groups and partners right now, because they're trying to design the trials and then hand them down to the researchers. And we're saying, no, you got to get the patients involved, and you got to start with the advocacy groups. And so, because there's a whole lot of us who could be tested, who met criteria way back when, and our doctors never offered us that testing.
Right.
It's like you get a grant for that work to be done, huh? I'm gonna work on that.
They're ready. They are ready when you are.
Because that's one of the things that happens, right? When you get a diagnosis, it's like you become so overwhelmed and not, thinking, the only thing you're thinking of, oh Lord, how do I stop myself from dying? You don't think about, well, especially if you're young, you don't think about what can I do to advocate for myself at this point? What are the steps that I can take? Who do I need to have in my circle that will not only encourage me, but educate me, empower me? All of those things, I think, and I'm really, really impressed with Erica and all the steps that she's taken to really, take that bull by the horn and say, I got this.
Make a plan.
Yeah, exactly. With everything else in life, right? We plan, and we say, okay, this is the path I'm going to take. But, life happens and things go awry. So how do we circle back and get our control, fix our crown and get our control back and say, okay, this is what I got to do.
And
Um,
Erica's
I'm-
a great
Also, how
example
do
of
we,
that.
I'm sorry, go ahead, Dr. Mel.
I was just gonna say, if you look at her advocacy work with Vassar and with the other organizations that she's done work with, you've worked with Erica with Vassar, right, Erica?
Yeah.
I'm in Philly, and
All right.
it kind of creates a blueprint for how people can get involved in this advocacy work and stuff. And even Nicole, you're a unicorn. There aren't enough genetic counselors, and so for people who go to community hospitals, they may not even have a genetic counselor. But finding a Black one,
Right.
Yeah.
Ricky, we got to talk about fortifying the pipeline and educating more GCs, because we need more counselors who look like us, who understand our unique considerations, and who can even tease out that family history for family members who sitting there like this.
Yes.
Well, I will say, Dr. Mo, I'm trying. I told the people at Vassar, I said, what you need to do is, I was like, you need to create a scholarship, because if you are a Black person in STEM, you have so many options. So how are you going to make genetic counseling appealing? And how you do that is to have scholarships. Now, as a first, I'm happy what they're doing is they are doing an internship program this summer for minority undergraduates who are interested in genetic counseling. So they will be able to rotate through the Vassar labs for 8 weeks. So it's a step where I want to be, where I want to see. And then there's also, I'll shout out Golden. There's an initiative by some of the Black genetic counselors to get more students from HBCUs into the genetic counseling pipeline.
Yeah.
Because only 2% of genetic counselors are Black.
Yeah. My whole time in the field has been 1%. So I'm happy that we're at 2 now.
Well, only you and somebody else, I think.
Well, you know what? Only 4% of doctors are Black.
Yeah,
So yeah, the medical profession has a long way to go.
Seriously.
So we have our HBCU internship program. So I'm going to try to figure out how we can. And we have a bunch of pre-med students, and they're these phenomenal young women. We have 7 now, and they are doing basically a social media campaign on breast cancer on their campuses, and we make them start out with a poll about what and then end with a poll 10 weeks later. And when they start with the poll, they get 0%. I don't know how to do a breast self-exam. I don't really know anything about breast cancer. Even when people with breast cancer in their family, by the end, we want to get like 70%. And so, but I would love to channel 1 or 2 of them into genetic testing. So let's talk about this later, because, we can have them work with you or whatever, and kind of work for you through us or something. But I feel so strongly that we have to educate young Black women, Erica, like yourself, because I also believe not only do they know, and they need to know about the careers, but they can be the voice into the family and uncover the secrets.
Yeah.
Well, see, that's
Grandma, what's up with that?
Yes.
Did you get your program? Because
Get
they
people to talk.
Yeah, they will get the talk started, and until we uncover all this stuff, open up all these channels and communication, and make it kitchen table conversation, we're going to keep dying. We got to stop it.
Right.
See, I think too, I think one thing I think about as part of the advocacy is I think sometimes I don't, I think we know because we're all in these spaces that Black women are at risk. But sometimes I just wonder, right, if the average Black woman knows, how much risk she's at just from being Black, right? And that's how you really start the process. Because when you realize, oh, I'm at a higher risk, then you start thinking, oh, these are the things I need to do. And then genetic testing and counseling might be a part of that plan, right? So I think it almost, I only learned recently, right? There's at least 2 organizations, I think American College of Radiology, they recommend all Black women at the age of 30 have a conversation about breast cancer risk.
Oh, good.
Because of how at risk we are.
We are.
Yeah. They don't
And so I think it's that education piece too. Like if I had the bandwidth, I would love to do something with the sororities, right?
Yes.
Or
Yeah.
the links or
Let's
someone
talk
like that.
about
Yes.
Let's talk about
Yeah.
Out there.
Let's talk about, we're starting to do some stuff.
Yeah, let's talk about the links as well. Ricky
Yeah,
and I are both links. So,
Yeah,
you know, and see, and so,
Also,
yeah.
okay.
And I actually happen to be, I'm on I'm one of the national officers. So let's talk about that.
That's awesome.
Yeah.
I'm actually going to speak at the Link Southern Area Conference in June, Dion. So let's talk about that.
So that'll be beautiful. Yes, yes.
Fantastic.
But we need to do all of that. We need to be talking to everybody, and
Yep.
and I'm hoping that even some of our interns, we have Prairie View, Howard, Spelman, A&T, FAMU, and hopefully they can even talk about their sorority, work within their sororities on their campuses. So
Mhm.
Yeah, that would be great.
Yeah.
The other thing, when you were talking about, information and what to do, how do you weed out the wrong information? Because I think one of the first things we do when we get diagnosed is to start looking on the internet for,
Dr. Google,
yeah, let's see what the cure is. We should take this or take that. How do we weed that out?
yeah, there's so much
I
better.
think going to reputable sources, like starting with, American Cancer Society, looking at breastcancer.org, looking at things like Touch and Tiger Lily, and the American Society of Genetic Counselors. And what are your societies, Nicole, where people can get valid and reliable information?
Yes, the National Society of Genetic Counselors has excellent information. I want to say also geneticcounselors.org. And if you go to nsgc.org, you can actually find a genetic counselor in your area, and they can break it down by the mile, by the specificity, because there are counselors outside of cancer. We have prenatal, cardio. So if there are family histories of other things, you can also find counselors there. So nsgc.org.
Yeah, we should put that in the chat.
Yes.
There's also
You did know. You're so good at that. No, you're so fast. Thank you.
there's also Force.
Force.
Facing
yeah.
facing our risk, cancer empowered.
Yeah.
Oh, okay.
Facing our risk. Yeah.
Or yep.
Bright Pink is another one.
Yeah.
Yeah.
Mhm.
So, well, and we're starting to build also a resource page on our website. So I'll put these up.
Untouched. That's
to
great.
get back into
Yeah.
people and stuff. So we're working on that right now, actually.
So let me ask everybody, sort of around round robin, what would you envision next as a result of this conversation, for one, but for people who might be watching, what are some next steps that they could take to get empowered, to get tested, to know their family history? Like give people some tips and some advice on how to navigate this stuff.
I really like what we started talking about talking to your family, like having that, kitchen table conversation, and then get genetic testing. You can make it a party. We're going to go get tested and, go out to lunch, go out for tea, go out for coffee. I mean, make it something fun. Everybody, do it together. It's not as scary.
I like that a lot. I actually have been thinking, I saw on the internet somewhere there are these books called the Legacy Journal. And I plan, as I said, Mom's 84, and if she's not well, there's some information that she loves to write. She two things. She thinks she's Einstein and Shakespeare. So and professionally, she was a clinical social worker. So but anyway, so I plan to collect her story. I plan to empower her to feed me that information, and I then will share it and disseminate it to not only my siblings but to their children, with the words of encouragement to keep this going, because it's up to us, and there's nothing more horrible than sitting in a corner saying, I wish I had done this. I wish I had known this. You know,
Yeah.
there's so much. I mean, an opportunity to learn from so many of you all here that are just passionate and engaged in really making a difference. Let's just take advantage of that.
Yeah.
Yeah,
Yeah.
Ricky, maybe on the Touch website, you could have like the, you know, like the story core kind of thing, you know, her story, and people could like, you know,
What's
all
your
we
her
do
story?
is, you
What's
know,
your her story? That's a
yeah,
great
just, you know, get out our iPhones and, you know, and tape, you know,
Yeah.
tape our loved ones talking and
Yeah, collect
you
those
know,
authentic voices, you know,
yeah,
and not, you know, and not saying, come on, tell me everything, but you know, let them feel that they're free to share as they want to share.
yeah,
Yeah.
Yeah, I got my mom an audio app to write a book. And
Oh,
so
wow.
writing her book. And so I make her, every morning I call her, okay, mommy, record a story of something.
that's great.
So we
Yeah.
can write a book. So we're actually now almost done with the book, but we started with a tape recording app.
Yeah, that's
So,
great.
That is awesome.
I would say just have that conversation, you know, and you got to have it on both sides, right? You got to have it with your dad's side and your mom's side if you can. If you've had a breast cancer diagnosis or an ovarian cancer diagnosis in the past, you definitely got to have the conversation. And then I would say just don't go alone. Like people are always like, how'd you do this? This is overwhelming. And it was because I used to deputize people to go to appointments with me. I was like, they're gonna be throwing a lot of information at me. And we got a game plan. We got to know what we got to get out the appointment before the appointment. And then we got to make sure that if I forget, because I'm overwhelmed, you're going to remember.
Right.
You're going to remind me of the things that I need to know, right? So yeah, I think sometimes we try to do this alone and it does not work.
No one fights alone. That's one of our lives.
It does
No
not work.
one for breast cancer. So do the same thing for genetic testing. I love that.
Yeah.
Yeah.
And I would like to
I
see
still call Ricky sometimes and go, what was my diagnosis? You know, I don't understand. And she'll go, you know, it was this, you know, you were like positive here, negative here. I'm like, okay, thanks. I mean, I was just like, you know, like deer in headlights. You know, I couldn't really think. So, I mean, that it is important. You're right about that, Erica. Don't go alone. Take somebody with you.
Yeah, and I was gonna say even just feeling strong enough to just ask your doctor to order the testing for you, because it's been too many times that doctors just haven't done it on their own for whatever reason. Like I just saw a patient this week who's on her third cancer, and no one has ever offered her any type of genetic testing. And I would say outside of that is to keep a copy of your results so that at any given time, you will know what you were tested for. You can share the results with your family. There isn't that big question of what did I have tested? And if you do need update testing, we'll at least be able to reference, you know, what you had originally. So just having the courage to say, hey, I have a family history. This is something that I know exists, and I want you to help me find access to it. If not, go to nsgc.org, you know, put in your zip code and find a genetic counselor in your area, and just keep a copy of your genetic test results to share with family.
We have an
I
awesome
saw
partner.
somebody-
They're called Citizen with 2 I's, citizen.com, where they digitize all your records.
Yeah.
Oh, wow.
I'll put that link in the chat too.
Yeah.
That way people can use it. Nicole, I saw somebody today who was 36 who had colon cancer and melanoma and never been offered any genetic testing. But the age of coronavirus, I will say this, one great thing that has come out of COVID is that people can now get counseling virtually. They can get
Yes.
testing kits at home, delivered
Yes.
to your home. And
Yes.
many of these companies won't run the test without checking with your insurance to make sure you meet criteria. So you're not going to just get billed thousands and thousands of dollars, but you can do all this from your home. If you don't have a doctor to go to or to talk to, which you should to help understand those results. But if you want to begin this process and educate yourself and or pursue this testing, there are
Yes.
websites you can go to now, and you can get a kit in your house. You
Yep.
spit tube, mail it off.
Yep.
You can get these results and take charge of your hereditary cancer testing. So you can,
Yep.
knowledge is power. And
Yep.
COVID has shown us that we can do a lot of that counseling virtually.
Yep. Absolutely.
Yeah, I know J Street is the one at Emory University,
Mhm.
where I think you send it off, but then they will connect you with a genetic counselor, even though you're doing it, you're doing the actual testing through the in the mail kit.
Mhm.
All the major companies now have them. They have
They
genetic
all-
counselors and educators.
Yep, they all do. You can talk to a counselor by phone. Even they'll send a phlebotomist out there if you know, for whatever reason can't do saliva. I mean, the options are endless. There are patient assistance programs. So say you do have an out of pocket that you really can't afford with other things going on financially, you can fit into those programs and they make them so extensive. I mean, almost everyone fits. So at this point, there's no reason for doctors to say, oh, your insurance may not cover it or this or that. You know, that's out the window at this point. Everyone should have access to this service.
That's great. And think about the people that are doing ancestry.com. It's the same thing.
Exactly.
Now you know about your health, you know,
Right.
so you know who your grandfather was, but know about your health. What did your grandfather die of?
Right.
Right.
Well, you know, the stuff
Right.
like that, like ancestry.com, does that count for genetic? Because they also do that. Like they'll do, you know, they'll tell you about like different health issues. Is that the same thing or is that not? No.
Completely different. So the
Oh, no.
consumer versus clinical are two totally separate areas.
Okay.
So you may get some feedback, but I would always go back to your physician or your genetic counselor and talk about that. So an example, a prime example is, you know, some of those testing companies may look at BRCA1 and BRCA2, but they may only report information on the 3 Jewish variants.
Okay.
So if you don't have a mutation in those 3 sites, then of course your result's going to come back negative. So you need a full comprehensive test done from a clinical lab and a meeting with a genetic counselor to do a 3-generation pedigree to make sure all the genes are included, you know, to make sure that you have the right information. So it's helpful in a sense, but, you know, take it with a grain of salt. But for any clinical information, you want to meet with a healthcare professional versus direct to consumer testing.
Okay. All right.
Step 1, talk to your family and don't take
Yes.
no for an answer, because it's past time for, you know, Nana died of something down there and somebody died of something and she had a mastectomy, but we're not sure what it was. And, you know, and that's how things used to be. And we
Yes.
understand that. I mean, we have some family members who may not even know their own birth dates, you know, and the years that they were born and their ages as a result of the Middle Passage experience, you know, so we get it, but it's time for us to really start to talk about our health. And I love that we are opening the door for those conversations. And, you know, if you're watching and you have changes in your family history and cancer in your family and you want to have these conversations, you can join our chat. They can join our group on Facebook, right? Touch Talk, Ricky, is that the?
Yeah, every first Saturday of every month at 1:00. Just email me, ricky@touchbbca.org. And you guys know how to find me on Facebook. Yeah.
Yeah. How can
Yeah,
we
we
find
find
everybody
that.
else and your organizations, your websites, your causes that you champion, and people want to follow you on social media? What can they do?
So my
Oh,
go ahead. Go
sorry,
ahead,
I'm sorry,
Dion.
Erica. So I'm at AARP. I'm the director of state operations. So if you want to know anything about being fabulous at 50 and older, it's www.aarp.org. And I'm here in Florida. My Facebook is DHE Polite. My Instagram is DHE Polite, as is my Twitter. I'm easy to find, and if you can't find me that way, Ricky knows how to get me.
I know, fine. And she posts fabulous stuff on Instagram. I love her stuff. It's great.
Oh, wow. That's
Yeah.
great. I will start following you, Dion. Actually, I'll start following all of you.
Yeah,
So
same.
I'm already following Ricky, of course, but yeah.
Dan's running for office too.
Oh,
Yeah,
All right.
November. Yeah.
Wonderful.
And so Jan, how do people reach you, babe?
Okay, so I'm Jan-Michelle with 1L .Kearney, KEARNEY at, this is too long, Cincinnati-OH.gov. You know what? Just Google me, Jan Michelle Lemon Kearney. You'll find me. I'm out there.
Or call me. I'll find her.
if you want to get in touch, my email is my name, so it's erica.stallings@gmail.com. I have a website where I collect all the writing and sort of patient work that I do. So that's ericastallings.com. And then my IG is Erica_M_Stallings. And I'm always open to collaborating. I was really excited to be able to do this. I'll go talk to lawyers. If you're open to let me come talk about genetic counseling and testing, I will show up.
Right.
Yeah.
I love that.
Yes. This is a great conversation. I just love it. So much information, and you know, the sharing is just really important. I mean, it's really important.
Nicole, what's your information?
Yes, so Nicole Thompson, I am a genetic counselor at Howard University Cancer Center. So if you're in the Washington, D.C. area, have a family history of cancer, or want to learn more, feel free to reach out. My Instagram is Nicole Genomics, and so is my Twitter, Nicole Genomics. My email is NicoleGenomics@gmail.com. So it's the same across everything. And I'm also open to collaborating, also open to research. I work with a very diverse population with different needs. So I'm always open to speaking and just learning more about what other people are doing in the field and how I can help, how I can contribute in any way.
Wow. Wow.
I think we should do this show again in a couple of months, Mo, right? Let's do it again. Maybe in October.
November is Family Health History
Yeah.
Month. So
Yes.
Oh, yeah, that's a
June.
great month to do
Yeah.
it. Yeah.
haven't talked about men and how this can affect men as well. And people always think, oh, it's just the women. So we're going to maybe have a split panel and be able to talk more about that too, because, you know, what if we're at risk for things like prostate cancer? And, you know, when do we start screening and what are the guidelines for all these things? So we definitely got to have this conversation again.
Ricky,
Love it.
June 17th, FDA said that's National Black Hereditary Cancer Week.
There it is.
Oh,
So
yeah,
we could
it's
do-
my birthday. That's my birthday. Okay.
Oh,
maybe we can do something that
yes.
week.
Oh,
it's-
wow,
Do something
that's,
that week. Yeah.
Perfect. Love it so much.
that's
Well, I'm
good.
Dr. Monique Gary on all social media outlets, the LinkedIn, the Facebook, the YouTube, except for the Clubhouse. I don't know what to do on there yet. But you can follow me, or if you follow Ricky, I'm following her. So everywhere she goes, I go. And we hope that this has been relatable and reliable and real, is what we set out to do every single
Mhm.
Wednesday night for our breasties, is to put out something that's going to inform people, empower people, and connect with us, because our stories are what gives us power, and it's what is going to change the face of Black breast cancer. So we are here for it. Ricky, any other thoughts or comments? Thanks to our sponsors and Black Doctor.
Like Dr. Adorg, thanks to Amgen. We're going to change the game, guys.
That's right.
Next week, we're talking about stress.
That's a good one. Oh,
That's a great
That's a good one.
Next week,
Love it.
you know, we'll talk about stress. So
We will
thank
be
you
here.
guys so much. You guys are so awesome. I love you dearly. Thank you
Thank
so
you
much.
guys so much.
Thank
for
you so
coming.
much.
thanks,
Yes.
everybody.
You
Thank
guys
you so
take
much.
care. Stay healthy.
Yes.
Get the vaccine. And also, you know what? We lost my Allison, but I know she's at rest and at peace. So thank you for all your prayers for her.
We love her.
Another angel.
Allison.
Rest
Yeah.
Take care.
Love you all of you. I'll see.
Love you guys.
Bye.